Hi, good evening. Good evening, everyone. I'm Dr. Gaurav Patel, and we'll be discussing today the recall questions of surgery which were asked in the FMGE January 2023. Okay, so I have these questions with me, and it's a live session. So if you want to add anything, all the listeners, if you have anything to add on or any correction if you have, because all these questions are like memory-based questions. So whatever question you have gathered, let's discuss those questions. Okay, so the first question. Male presented with swelling in the inguinal region. Okay, this is the swelling. Did not have any discomfort or pain. He presented because of the swelling, and it is reducible, and it reappears when the patient is asked to cough. Okay, so reducibility is present, cough impulse is present, reducibility is present. You can see very typical swelling in the groin area. Which of the following is the treatment in this patient? So this is a hernia. Okay, inguinal hernia, and this is a uncomplicated, basically, because patient is having concern only about the swelling. Uncomplicated inguinal hernia. So in case of adults, the treatment, because the patient is a young male, so the treatment is hernioplasty. Hernioplasty, in which we will put a mesh. There is no medical management for hernia. Wait and watch may be done in the patients when the surgical risks are too much, like in elderly patients or in severe comorbid patient. If it is uncomplicated, you can wait and watch. Here the patient is young, so no comorbidity as such, so treatment is like justified. Herniotomy is for the pediatric patients. Okay, pediatric patients where we don't put a mesh, we'll just repair we find the hernial sac and to the repair. Yes, Sandeep Sharma, that is correct. Hernioplasty is the answer. Okay, next question. Genetic testing for BRCA1 or BRCA2 gene is indicated in all of the following except. Okay, so in which case you will consider it as a hereditary breast cancer rather than a sporadic breast cancer. Male breast cancer, that is true. Bilateral breast cancer, that is true. Breast and ovarian cancer in the same patient, that is true. Breast cancer diagnosed in a postmenopausal female more than 50 years old. Okay, this is incorrect. It should be less than 50 years of age. Okay, if it is diagnosed in a younger patient. Okay, less than 50-year-old. Apart from that, if there is triple negative breast cancer, okay, you will consider it as hereditary and do the BRCA1 and 2 testing. And if the patient belongs to Ashkenazi Jewish heritage, then also you can do the testing. Okay, so these are the common things: breast cancer, ovarian cancer in the same patient at the same time, or if there is, like, suppose a patient is having a history of breast cancer, history of ovarian cancer, and now she is having breast cancer, then also you will go for it. So C is the answer. Okay, it should not be more than 50, it should be less than 50-year-old. Yes, Sandeep, that is also true. Okay, next question. Just tell me, Sandeep, whether this question was there or not. A patient presented with a swelling on the anterior border of the sternocleidomastoid in the upper part of the neck. This swelling represents the remnant of which of the following branchial cleft? Okay, so this is a swelling present on the anterior border of sternocleidomastoid in the upper part of the neck. This is very typical of branchial cyst. Okay, that is remnant of the second branchial cleft. Okay, so this branchial cyst, and there is a branchial fistula. Okay, so the cyst is present in the upper 1/3 of the neck, and in the fistula, the external opening is present in the lower 1/3 of the neck, and internal opening is present in the tonsillar fossa. Okay, hi, good evening, Raj. Okay, so few people, they said, a few students, they were saying that this question was not there. So if any of you can confirm whether this question was there or not about the branchial cyst, the second branchial cleft remnant. Okay, so both are, see, there are these branchial anomalies, and most of these branchial anomalies are mainly because of the remnant of the second branchial cleft. Okay, so this question, upper part, anterior border of sternocleidomastoid, it is branchial cyst, and that's why the answer is second cleft. Urine output starts reducing in which type of shock? Okay, so if you see the classification of shock, class 1, 2, 3 and 4. 1 is, you can say it is compensated. 2 is mild, suppose 3 is moderate, and 4 is severe. Okay, so in this, if we just see the urine output, in type 1 it is more than 30 ml per hour, more than 30 ml. In 2 it is 20 to 30 ml. In 3 it is 10 to 20 ml. In 4 it is either less than 10 or it could be nil. Okay, so more than 30, that is considered as normal. 20 to 30, that is mild. Moderate is 10 to 20 and severe is this. So it starts reducing in which type of shock? Okay, so if you consider this as the compensated shock is when the blood loss is less than 15%. So it will start reducing from the mild shock only. From the mild shock it will start reducing. Okay, because it will be less than 30 ml in that case. Mild shock. Okay, so 20 to 30 ml, it starts decreasing. They have not asked in which type it will be low or it will be nil. It will start decreasing from that type 2, the mild. Okay, if these were the options. If it was like type 1, 2, 3 and 4, then 2 will be the answer. If it was like that. Okay, and if it was like mild, moderate, severe or compensated, then it should be on the mild shock it will start reducing. Q-SOFA, quick SOFA sequential organ failure assessment score include all of the following except respiratory rate, yes, correct. Systolic blood pressure less than 100, okay, it should be less than 100, that is correct. Altered mental status, GCS less than 15, that is also correct. LDH is not seen, and that is the answer, LDH. Okay, lactate dehydrogenase, this is the answer. LDH was in the option or something else was there in the option? Option number D. Whether it was LDH or something else. Yes, Raj, correct, D. Okay, so I guess it was LDH only. So LDH is not seen. The respiratory rate, systolic blood pressure less than 100 and altered mental status. All these three things are seen in quick SOFA or Q-SOFA score. Yes, correct, Sandeep. Okay, this question has been asked repeatedly in the exam, and trauma is also one of the very important topic for the exam. 34-year-old male rushed to the emergency after road traffic accident, unconscious. After some time, patient regained consciousness. A plain CT was done and the image is given below. And you can see a very nice biconvex shape lenticular opacity. Biconvex or lenticular hyperdense lesion. Okay, so this is typical of EDH. Yes, Rajneesh, Ritu, it is EDH. Okay, in SDH you will see something like, suppose this is a CT, you will see something like this. Okay, this is what you get in SDH, a concavo-convex type of opacity. This is typical of EDH. And in the question, if you see, patient initially unconscious, then he regained consciousness. So looking at the size of the hematoma, he might become unconscious again. And this period of consciousness in between, that is lucid interval. Okay, because the initial period of unconsciousness is because of when there is impact, there is concussion, and then he gained the consciousness, and then again he becomes unconscious because of the, you can say, the size of the expanding hematoma. Yes, sickle or concavo-convex type of opacity. Next question. Patient was brought to the emergency after RTA. Skin grafting was done where the graft was taken from the same person. Okay, skin grafting is usually done from the same person. You can take the graft depending on whether you are using a partial thickness or the full thickness. Partial thickness is usually taken from the thigh, anterolateral aspect of the thigh. Full thickness, depending on the area, you can take from the eyelid or post-auricular area or elbow. Which type of graft this will be? Okay, so this is very simple, autograft. Okay, isograft is from the genetically same individual. Genetically same individual means like a monozygotic twin. Monozygotic or identical twins. Allograft is same species. Like suppose it has been taken from a human only, and xenograft is different species. Like in case of burn, sometimes they apply the pig skin or the fish skin. Okay, so this is autograft. Rajneesh, it is autograft, not iso. Iso is genetically same if it is taken from a twin, monozygotic twin. Okay, so it is autograft, not isograft. Okay, the correct answer is autograft. Okay, any confusion in this? It is autograft. Ritu, Rajneesh, Sandeep, Raj, it is autograft. Same person, autograft. A patient was recently operated and laparotomy was done. Patient developed a complication after the surgery. What would be the surest sign of wound dehiscence in this patient? Wound dehiscence or abdominal wall dehiscence. Okay, abdominal wall dehiscence. It is when there is a serosanguinous discharge from the wound. Okay, serosanguinous discharge from the wound. This is usually seen from the 5th to 7th day of surgery. Okay, serosanguinous discharge. It will be discharge which is more of serous and a little bit of fluid, kind of pinkish colored discharge. Okay, that is the surest sign or the telltale sign of abdominal wall dehiscence. Okay, abdominal pain is not seen. Usually you will see the bowel comes out. Okay, when the moment you will open the skin suture, you will see the bowel is coming out. Hypotension is not there. Bleeding from the wound site occurs if there is any injury over that exposed bowel, then it can lead to bleeding. Otherwise, the telltale sign or the typical sign is the serosanguinous discharge from the wound. Okay, so B is the answer in this. Yes, most of you are correct. Next question. 73-year-old chronic smoker, male, OPD with the following. Okay, if you can see, there is a dry gangrene. What is the diagnosis? Now see, I'm sure you get confused because of the smoker, but you have to see the age also. Okay, although in the smokers, Burgess disease are seen. Okay, smoking is definitely associated with Burgess disease. But in which age group usually it occurs? It occurs in 25 to 40 years. This is the age group of Burgess. Atherosclerosis is seen in more than 60-year-old. So in that age group, the most common cause is atherosclerosis. No, even immediate sign of the wound dehiscence, Sandeep, it will not be pain abdomen. It will be discharge only. Okay, patient does not complain of pain in that case. It will be discharge only. Pain is not a feature of wound dehiscence. Okay, it will still be discharge. Okay, so the answer here is atherosclerosis. Yes, Charmish Goswami, you are correct. It is atherosclerosis. Burgess disease you will not see in 73-year-old patients. Even if they are smoker, if Burgess has to cause, if the Burgess was the answer, then the age of the patient would have been less than 40 years. See, dry gangrene is when there is a, you can say, gradual decrease in flowing of the blood. Gradual decrease in flow of blood over the period of months or days. So this will cause the kind of tissue it will be dry, shriveled, mummified limb. Dry, shriveled, mummified limb. Gradual decrease in the flow of blood. So this will cause dry gangrene, like this appearance. In wet gangrene, there will be sudden occlusion of either artery or vein. Sudden occlusion of artery or vein, or both, that will lead to wet gangrene. And wet gangrene is mostly it will be a spreading type, and it can lead to sepsis. Dry is not infective. Okay, it will not lead to sepsis because there will be a very nice line of demarcation there. Okay, you will see very nice line of demarcation that will tell you that okay, the area above this is gangrenous, below that is gangrenous, and above is healthy. In this case, in wet gangrene, there is no line of demarcation. Okay, so answer here is atherosclerosis. Both atherosclerosis, Buerger's disease, they will cause dry gangrene only. Wet gangrene can occur because of, generally in the intestine, it will be wet gangrene, or if there is sudden occlusion of the arteries or vein, that can lead to wet gangrene. Next question. Which of the following is the least commonly used graft in coronary artery bypass graft? In this, the most commonly used for this coronary bypass surgeries is left internal memory artery. This is the most commonly used. And great saphenous vein is also used. Long saphenous vein is also used. So generally when we do the surgery, when the people they do the surgery, they take both the grafts. They take the left internal memory artery and they take the great saphenous vein also, especially in case of triple vessel disease. When they need more graft, they take both the grafts. Okay, so these are the common grafts. Radial artery may also be taken when they need more graft, or suppose the patient underwent some kind of stripping of the vein or the varicose vein surgery and the great saphenous vein is not available. Then the radial artery can also be used, but intercostal arteries are not commonly used. Okay, so that is the answer. Intercostal artery is not commonly used. Intercostal artery is the answer. Okay. Yes, correct. Rajneesh, correct. Intercostal. Okay, like in this case, just see if there is above inguinal ligament, like the peripheral artery, like ioto-bifemoral or axillo-bifemoral, then the most commonly used graft is Dacron. Okay, below inguinal ligament, like femoropopliteal bypass. Femoropopliteal bypass. Then the most commonly used is reversed saphenous vein graft or the great saphenous vein. That is known as reverse saphenous vein graft. Okay, so above the inguinal ligament, if you are doing any bypass surgery with the aorta, use Dacron, and if you are using like femoropopliteal bypass, use the great saphenous vein, and you reverse it so that the valves does not come in the way of flow. Gold standard treatment for varicose vein should be. Okay, for the so many years, for so many decades, the gold standard treatment for varicose vein was ligation and stripping. Okay, older gold standard. But now they say that for the varicose vein, endothermal ablation is the gold standard treatment. Okay, for over the past, you can say 10 years, endothermal ablation like radio frequency ablation or endovenous laser ablation has evolved as the gold standard treatment for varicose vein. Okay, yes, correct. Endothermal ablation is now the treatment of choice. Sclerotherapy is usually done for small veins like telangiectasia or reticular vein. Okay, so for these veins, sclerotherapy is, you can say, the gold standard treatment. But for varicose vein, and I hope you know the difference between these three, telangiectasia is when the diameter of the vein is less than 1 mm, reticular is 1 to 3 mm, and varicose vein is more than 3 mm. Okay, so for varicose vein, RFA or EVLA, and for telangiectasia or reticular vein, sclerotherapy is the gold standard treatment. In sclerotherapy, will give sodium tetradecyl sulfate. Yes, correct. Okay, next question. Which of the following is the main risk factor for acute mastitis? Acute mastitis, or you can say like breast abscess, engorgement of the breast, absence of lactation, cracks in the nipple, hormonal influence. See, all these three are the risk factor, but the main risk factor is cracks in the nipple. Okay, because through this, the bacteria, that is Staph aureus, usually this acute mastitis you will see in lactating females. So the bacteria from the oral flora of the child, it enters into the breast through the cracks in the nipple and goes inside and causes breast abscess. Okay, so cracks in the nipple is the reason. And remember, these days breast abscess, the treatment is not straight away incision and drainage. Now the treatment is IV antibiotics and needle aspiration. Okay, you have to aspirate the abscess. You don't have to go for incision and drainage straight away. If this treatment fails, then you go for incision and drainage. Antibiotic of choice in this case is amoxicillin. Amoxicillin plus clavulanic acid, that is it comes with the brand name of Augmentin. Okay, I hope all of you know amoxicillin. Okay, amoxicillin plus clavulanic is the antibiotic of choice. Okay, so this is the answer, cracks in the nipple. Which of the following is true about the pathology shown in the image given below? So this image is of cleft lip. Okay, see, very quickly we will see when the face formation occurs, there are 5 processes. One is known as frontonasal process, 2 maxillary process, and 2 mandibular process. Okay. All these things, they will join and forms the face. In the frontonasal process, there is something known as median nasal process and lateral nasal process. So lateral nasal process will form ala of the nose, that has nothing to do with the lip or the palate. In maxillary process, there are palatine shelves. Okay, so there are 2 types of cleft lips. The central cleft lip is when the philtrum part is absent. Okay, like suppose this is the central cleft lip. This is because of non-fusion of 2 halves of median nasal process. But the common one is the lateral cleft lip, where the philtrum part is there. You can say the philtrum part is there. There is defect is present usually laterally like this. So this is because of non-fusion of this median nasal process with the maxillary process. Okay, failure of fusion of median nasal process and the maxillary process forms the lateral type of cleft lip. Okay, the central type is because of non-fusion of 2 halves of median nasal process, and the cleft palate is because of failure of this palatine shelves in the midline. Lateral nasal process does not, it has nothing to do with the lip. It will form the ala of the nose. This option number A will cause cleft palate. And again, mandibular process has nothing to do with the cleft disorders. Okay, so this is clear. The answer is B. A newborn baby on the second day of the life was found to have a continuous frothing of saliva from the mouth. In the emergency, the patient comes and image is shown. The image is showing a chest x-ray. Identify the pathology, and if you can see closely the chest x-ray, you can see there is coiling of this nasogastric tube. Okay, coiling of NG tube or the nasogastric tube or the Ryle's tube. So this coiling occurs when there is esophageal atresia. Okay, this is esophageal atresia. Now suppose there is trachea. If it is a pure esophageal atresia, that is type A, I hope you know what is type A, then you will not see this gas in the stomach or in the GIT. So gas in the stomach is seen only if it is communicating with the trachea. Okay, now the air will go through this and gets accumulated in this. And this is type C, which is also the most common tracheoesophageal fistula. Okay, so B is the answer. Tracheoesophageal fistula, and which type? Type C. That is approximately 86% of the tracheoesophageal fistula are of this type. Okay. Hypertrophic pyloric stenosis, they will present first of all not on the second day of life, they will present later on, usually from the 4th week to 6th week with a non-bilious projectile vomiting. Duodenal atresia will present as a bilious vomiting. Jejunal atresia will also present as intestinal obstruction, distension, and bilious vomiting. Here the patient is having frothing of saliva because of tracheoesophageal fistula. Okay, this is not true about IHPS. There is hypertrophy of, there should be circular muscle fibers. Okay, circular muscle fibers, not longitudinal. Ultrasound is the investigation of choice, 100% sensitive modality, that is correct. You will see the thickening in the area, thickening at the pylorus more than 4 mm, and the length of that area is more than 16 mm at the pylorus. Presents with projectile, so this is correct. Projectile non-bilious vomiting, that is correct. Baby is dehydrated with metabolic alkalosis, that is also correct. And with paradoxical aciduria. Okay, hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria, that is a typical electrolyte imbalance in these cases. So option number A is the incorrect, rest of the statements are correct. Yes, very good, Wasim Akram, very nice. Okay, so that is a patient in the OPD with hematuria. He has been suffering from recurrent episodes of UTI. Identify the pathology in the image. This is the CT they have given, and in the CT you can see the right kidney, the left kidney, and both the kidneys are joined in the center. This is the isthmus, so this is a horseshoe kidney. Horseshoe kidney. Okay, on the horseshoe kidney, on the IVP, you will see the hand joining sign or the flower vase appearance, but on CT scan, you can see both the things are there, joining. Yes, correct. That is, you will see on IVP, this hand joining sign or the flower vase appearance. Polycystic kidney disease, the kidney will appear having this kind of thing, and mostly it is present on both the side. Okay, this is what you'll see on the CT of this. Hypernephroma is RCC, so obviously this is horseshoe kidney. The isthmus is present at the level of L4, L3, L4 basically, and the ascent is prevented by inferior mesenteric artery. Okay, good evening Vaibhav, welcome to the discussion part. So this is horseshoe kidney. As per the ATLS guidelines, which of the following is not included in the ABCD? A is for airway, that is correct. B is breathing. C is circulation. D stands for tell me what does this D stands for? Okay, it stands for disability. Disability is basically the neurological status. in which you will see the GCS, you will see the pupil size. Okay, so D is the answer. There is one more thing. EE is exposure and environmental control. Okay, so this was easy, straightforward question. 9-year-old presented to the emergency with this image of it is a foreign body ingestion. Looks like a coin. Most appropriate treatment in the baby should be. Okay, so the first of all, few people were saying that there are two images. There was one lateral image was also given. I don't know whether it was lateral image or only this image was given, but it is a foreign body. If it is given as in the lateral image, then it is very easy to differentiate whether it is in the trachea or in the esophagus. Okay, so if the air is present, if the coin is present in the trachea, then usually the babies will have severe respiratory distress, which is not given in this case. So it looks like it is present in the esophagus. So in the foreign body, esophagus, and it is present in the upper esophagus only. So esophagoscopic removal or the upper GI endoscopy and removal is the answer. Okay, esophagoscopic retrieval should be the answer. No need of doing tracheostomy in these cases. Okay, Heimlich maneuver is usually when it goes into the upper, when it is obstructed at the cricopharyngeal level. Laryngoscopic removal is for the laryngoscopic or basically the bronchoscopic removal. If the coin is present in the trachea, then we have to go for the bronchoscopic removal. Okay, so esophagoscopic retrieval is the answer in this case. Identify the arrow marked in the image given below. Okay, so this is a barium meal image given. You can see the stomach. Okay, there is a fundus body. This is the pyloric antrum, and then there is pyloric sphincter, and the arrow is showing this. Okay, so this is basically the first part of duodenum. Okay, first part of duodenum. It comes like this, and it goes like this. Okay, so this is the pyloric canal, pyloric antrum. At the level of pylorus, there will be narrowing, which is shown like this. This is the pyloric sphincter, and then you will see first part of duodenum. Okay, so this is first part of duodenum. This is first part of duodenum. Now, Wasim, even in case of a normal barium meal also, you will see something like this. In a normal barium meal also, you will see something like this, the first part of duodenum. Okay, so this is the first part of duodenum. Then there is this pyloric antrum or the pyloric canal. Here you will see the pyloric sphincter. Narrowing part will be pyloric sphincter. Even in the normal individuals, that area is narrowed down because there is a sphincter there. Okay, there is a sphincter there. So this is first part of duodenum. Most common feature in, I don't know whether the question was in all types of shock or in shock overall. In all types of shock, it is hypoperfusion of the tissues. No doubt about it, hypoperfusion of the tissues, and because of this, the tissues, they will go to anaerobic respiration, and because of anaerobic respiration, the byproduct is lactic acid, and the patient have acidosis or increase in the serum lactate in all the types of shock. Raised blood pressure in the shock, there will be decreased blood pressure. Increased respiratory rate may be seen in the shocks, but in the compensated state, you will not see this. This again, you will see from the class 2, 3, 4 type of shock. Okay, so hypoperfusion of tissue is seen in all the types of shock, whether it is mild shock or the moderate or the severe. Even in the compensated, you will see a little bit of hypoperfusion, and the serum lactate level will be raised and the base deficit will be high in those cases. Okay, so hypoperfusion of tissue is the correct answer. Next question, adult male with duodenal ulcer, minimum chances of recurrence would be seen. Okay, so these two are not the treatment options for the duodenal ulcer. For the duodenal ulcer, we'll go for although these days surgery for the ulcers are very rarely done. Only in the cases of complication we do the surgery, because mostly the ulcers are managed conservatively with the H. pylori eradication and different PPI drugs. If at all we have to go for surgery, truncal vagotomy and highly selective vagotomy. Highly selective vagotomy is more commonly done and there is less morbidity, because there is no need of additional drainage procedure. Drainage procedure is not required. Drainage procedure like pyloroplasty or gastrojejunostomy is not required. Truncal vagotomy, although there is increased morbidity because of the stasis, but there is minimum risk of recurrence, because if you cut both the vagus at the trunk, then it will not occur. And to make it a better thing, truncal vagotomy plus enterectomy. If you do this surgery, because when you do enterectomy, you will take care of the gastrin level also. So truncal vagotomy with enterectomy, you can say that patient, the recurrence of ulcer will not be seen. In highly selective vagotomy, there is increased risk of recurrence if you leave any of the, any of that selective vagotomy, any of the branch which is supplying the fundus or the body, then it will lead to recurrence. Okay, so minimum chances of recurrence, truncal vagotomy. Chronic alcoholic presents to emergency with sudden onset of upper abdominal pain radiating to the back with anorexia, nausea, occasional vomiting. Amylase was raised. It is a very clear cut and one of the easiest question. It is typically acute pancreatitis. In acute cholecystitis, there will be pain in the right hypochondrium, and usually this is seen in females. It has nothing to do with the alcohol intake. Acute appendicitis, pain in the right iliac fossa, which initially starts in the umbilicus and then radiates or migrates to the right iliac fossa. Chronic hepatitis generally does not come as sudden onset of pain. Okay, there will be gradually, there can be pain, and mostly they present as jaundice or weight loss or anorexia. So this is very typical history. Acute pancreatitis, amylase was also raised, although lipase is more sensitive and specific, but amylase they have given in the question. Next question, treatment of the pathology shown in the image below. Okay, I don't know whether the image was of CT coronal section or it was of IVP. I have put both the images. So this is a stone seen in the lower ureter, and in the CT also you can see the stone in the lower ureter. So in the ureteric stone, this is PCNL, sorry. The treatment of choice for ureteric stone is URS. Okay, ureteric stone. In the question, the size was not given, but suppose if it is less than 5 mm, then there are high chances of spontaneous passage. Wait and watch. Ask the patient to take plenty of fluids. 5 to 10 mm. You can go for either medical expulsive therapy or you can go for ESWL. And more than 10 mm, ureteroscopic removal of stone. Okay, in medical expulsive therapy, mainly we give alpha blockers, alpha 1A like tamsulosin, or calcium channel blockers can also be given. PDE5 inhibitors can also be given. So that will relax the smooth muscle of the distal ureter and the bladder, and it helps in the passage of the stone spontaneously. Okay, so URS is the answer in this image. Which of the following is least likely to cause bilateral hydronephrosis? See, suppose this is the ureter, bladder, and so anything which causes obstruction from the bladder neck distally, anything which causes bladder outlet obstruction will cause bilateral hydronephrosis. Okay, so phimosis. Obviously, phimosis will cause bilateral hydronephrosis. Posterior urethral valve, it is present in the urethra, it will cause bilateral. Urethral stricture, it will cause bilateral. Retrocable ureter, it is seen on the right side and usually it gets obstructed because of the IVC, and you will see only the proximal 1/3 of the ureter is dilated, and on the right side you will see hydronephrosis. It will not cause bilateral. Okay, so retrocaval ureter will not cause a bilateral hydronephrosis. Next question, management of a patient presenting with symptoms of BPH in the early stages. Okay, BPH, early stages, you will go for the medical management. In the medical management, you have two classes, alpha blocker and 5-alpha reductase inhibitor. Okay, so mostly alpha blocker, it will decrease the, you can say it will relax the smooth muscle. Relax the smooth muscle of the prostate, and 5-alpha reductase will inhibit the step which converts testosterone to 5,1,5-dihydrotestosterone. Alpha blocker, the effect starts within a month. Usually in 15 to 20 days of starting the drug, you will see the effect. In this, the effect might take 3 to 6 months. The example of this is finasteride, dutasteride. An example of this is tamsulosin, alfuzosin, sildosin. Okay, so when we start the treatment, we start with alpha blocker. We either start with alpha blocker or a alpha blocker with 5-alpha reductase inhibitor. We don't start the treatment with only 5-alpha reductase. Okay, so the answer here is tamsulosin. TURP is indicated only in certain conditions, when it is causing hydronephrosis or the renal insufficiency or acute retention, or when there is gross hematuria. So, and recurrent UTI, in those cases we'll go for TURP. Conservative treatment is usually, it is not going to help in any way. Okay, so tamsulosin is the answer. Okay, so you never start dutasteride or finasteride alone. You give it as a combination with the alpha blocker. Next question, in which type of pelvis the chances of hernia is more common? It is obviously the chances of hernia is more common if the pelvis is wide and short. Okay, short and wide pelvis. Because then if it is wide pelvis, it will be taking lots of intestine in it, and short means there will be the inguinal canal will also be short, and then in that case the chances of hernia is more common. Okay, kind of a anatomy question, you can say. Patient presents to the OPD with serous and pus discharge from the opening in the perianal region. It is basically fistula in ano. They asked what is the investigation of choice, and this question has been asked multiple times, that the investigation of choice is MRI. MRI or MR fistulogram. Okay, because this will tell you everything about the fistula, where is the external opening, where is the internal opening, and what kind of fistulous tract it is, whether it is simple or it is complicated. So every information which you need to know to treat a fistula, you will get by MRI. Yes, Wasim, that is correct. Patient who is a chronic tobacco chewer for more than 20 years presented in the OPD with a thick white patch on the lateral border of the tongue for the last 7 months. White patch in the oral mucosa which is not scraped off and which cannot be characterized as any other lesion is leukoplakia. What is the next line of management in this patient? Okay, so see, it is a thick white patch. Suppose it is very minimal and thin white patch, then in that case you can ask the patient to stop tobacco and wait and watch. Okay, for thin type of leukoplakia, but it is thick, so you do the biopsy. Why the biopsy is required? Because you want to know that in this biopsy whether there is any dysplasia is present or not. Okay, you want to see whether there is any dysplasia, whether there is mild dysplasia, moderate or high grade dysplasia. And many times when you take the biopsy, you might find a focus of in situ cancer. And these days, some types of leukoplakia like speckled or nodular type are very, very dangerous. They contain, there are very high risk of like speckled or nodular type. they have very high risk of malignancy. Okay, so that's why, because it is thick white patch, you are taking the biopsy to make sure that it is leukoplakia only and not dysplasia or not a in situ cancer. Next question, a homosexual male presented with rectal prolapse. I guess in the question there was something coming out from the anus. On clinical examination, there was a growth at the anal bulge. Anal bulge, or basically it must be in the anal canal, which is diagnosed as squamous cell cancer of the anal canal. Which of the following is the most adequate treatment? So the question is, what is the treatment of squamous cell carcinoma of the anal canal? And it is chemoradiation, okay, known as Negro's regimen. Okay, you will give chemotherapy, basically a cisplatin and 5-fluorouracil based chemotherapy, and cisplatin plus 5-fluorouracil and 45 gray of the radiation, Negro's regimen, and the tumor will totally disappear. Okay, and if it is adenocarcinoma, or suppose there is recurrence or there is residual disease, then in those cases you have to go for APR. Okay, APR you will do abdominoperineal resection if there is recurrence, if there is residual disease, or if there is any other type, adenocarcinoma or melanoma, then you go for APR. Otherwise, the treatment of choice for the squamous cell carcinoma of anal canal is chemoradiation. Which of the following is not true about the nephroblastoma? Nephroblastoma is another name for Wilms tumor. It mainly spreads by the hematogenous spread, but it can spread by the lymphatic, so that is true statement. Early lung metastasis can be seen, true statement. Treatment is, see, both the treatments are there. There are treatments when you give first chemotherapy and then surgery, or you can do surgery and chemotherapy. So both the treatment options are there. In the US and in the India, mainly first we do a radical nephrectomy and then we give chemo. In the European countries like UK, they give chemotherapy first and then they go for surgery. So both are true. It is the commonest intra-abdominal malignancy in children. This is incorrect. The commonest is neuroblastoma. Neuroblastoma is the commonest intra-abdominal malignancy in the pediatric age. Okay, so D is the answer. Rest of the statements are true. Next question, 55-year-old lady, painless hematuria, swelling in the left flank, 4 cm ballotable mass was felt in the left flank region. Urine cytology is malignant cell. Next line of the treatment. Okay, so this is ballotable mass, means it is renal cell carcinoma. Okay, and there is also painless hematuria. So renal cell carcinoma, chemotherapy has not much role in RCC. Intravesical BCG is mainly for the bladder cancer. Now, removal of the tumor from the kidney by dissecting through its various layers or radical nephrectomy. These two options we have. So this basically, this they are talking about, this is a partial nephrectomy. Partial nephrectomy or nephron sparing surgery. So the tumor is 4 cm. We can very well go for this 4 cm tumor. You can go for partial nephrectomy or nephron sparing surgery. Okay, so that is the answer. Removal of the tumor from the kidney by dissecting through various layers. That is the treatment. Basically, you need to take out the tumor and a part of the kidney which is having this tumor. Okay, now if the options were something else, you let me know, because then the answer would have been radical nephrectomy, but giving 4 cm in the question and an option which closely represents a partial nephrectomy or nephron sparing surgery, then that should be the answer. Okay, if anybody wants to add anything in this particular question. Was the question like this, or there was some other information given in the question? Okay. Next we'll see which of the following is the preferred treatment in muscle invasive bladder cancer. Okay, so if it is non-invasive or invasive. In non-invasive, you can go for TURBT, transurethral resection of bladder tumor, followed by either intravesical chemotherapy or intravesical immunotherapy, in which you will give BCG. So this mitomycin C is the intravesical chemotherapy. In the invasive cancer, which was the question, first you will give neoadjuvant chemotherapy and then you will go for a radical cystectomy. Radical cystectomy. Okay, so that is when you do a radical cystectomy, you will remove this prostate also. So this is cystoprostatectomy, or the radical cystectomy is the answer. Neoadjuvant chemotherapy, when you give, you will not give mitomycin C. The chemotherapeutic regimen is methotrexate, vinblastine, adriamycin and cisplatin. Methotrexate, vinblastine, adriamycin and cisplatin. This is the chemotherapy you will give. Mitomycin C is given as intravesical chemo. Okay, so this treatment is for non-invasive tumor. And the question was muscle invasive bladder cancer, then cystoprostatectomy or radical cystectomy. Yes, very good, Wasim MVAC. Next, 34-year-old male with hypertension, palpitation and diaphoresis. What will you suspect? Very typical hypertension, palpitation and this diaphoresis is pheochromocytoma. Pheochromocytoma. Adrenal adenoma can be functional or non-functional. Functional can present as either as Cons or Cushing's or virilizing or feminizing, or it can just present as a mass, as a non-functional. Adrenocortical carcinoma, most commonly it is also non-functional. 50% of the time it is non-functional. 30% of the time it presents as Cushing's. 20% of the time it presents as either feminizing or virilizing adenoma, and just 2% of the time it can present as Cons. Okay, so this is a very typical of pheochromocytoma. Hypertension being the most common hypertension you will see in 90% of the patients of pheochromocytoma. Next question, very typical. Body orange appearance in the breast cancer is due to blockage of the lymphatic channel. Okay, superficial or the subdermal lymphatics, that is the answer. Okay, there is no doubt, I am sure all of you must have marked it correctly. Superficial lymphatic channels. Now I don't know whether the picture was same or it was different, but as if you look at this picture, there is 2 centimeter mass, mobile axillary lymph nodes, and if you look at this picture, there is ulceration. Okay, so if there is ulceration, then the size of the tumor is not important. Now it will straight away become T4B. A is when there is involvement of the chest wall. That history they have not given, but obviously there is ulceration, so it will be T4B. Mobile axillary lymph nodes means it is N1 and does not involve any other organ, it is M0. Okay, so T4B, N1, M0, option number B. Okay, so if it was the same picture like the Altaf is saying, then it will be T4B, N1, M0. Okay, skin involvement, mobile axillary lymph node and no systemic involvement. So T4B, N1, M0. Identify the instrument in the image given below. Okay, so this is the instrument which is known as linear cutter and stapler. Linear cutter and stapler, also known as GIA stapler. GIA stapler means gastrointestinal anastomosis stapler. Okay, so this is the answer. Circular stapler will look like this. There is an anvil and then there is a main piece. This is a knob here and this is the handle. This is the circular stapler. This is used for end-to-end anastomosis. Linear stapler is used for side-to-side anastomosis. Okay, there is nothing like straight or curvilinear. This circular stapler can be a curvilinear type, or it can be a straight type. So mainly there is circular and linear stapler, and this is a linear cutter and stapler, or GIA stapler. Yes, Altaf, you're correct. It is linear stapler. The surgeon is doing upper GI endoscopy. He has crossed the cricopharyngeal sphincter. He saw another indentation in the esophagus. This is related to which of the following? Okay, so if you see the normal constrictions in the esophagus at 15 centimeters from the incisor, okay, you will see the distance from the incisor. You will see the cricopharyngeal sphincter. At around 25 centimeter, you will see because of the aorta and the left mainstem bronchus. And at the 40 centimeter, you will see GE junction. So this 25 centimeter is actually, there is aorta also and left mainstem bronchus also. But if you see aorta is present, you can say if you divide this, aorta is at around 23 centimeter and left mainstem bronchus is at 27 centimeter. Okay, this is 27 and this is 23. So if you have to mark between, if both were in the option left mainstem bronchus and arc of aorta, then the answer will be arc of aorta. Okay, if both were in the options arc of aorta, and suppose any one of these were option, then that will be the answer. Okay, because at 23 centimeter there is aorta and 27 there is left mainstem bronchus. Okay, so C, that's why is the answer. Next question, patient presented with severe chest pain, nausea and shortness of breath. CT was given. And in the CT, you can see these are the lungs. This is the pulmonary artery. This is the ascending aorta. This one is the descending aorta. This appears normal, but if you can see, there is this line. This suggests that there is dissection, aortic dissection. Aortic dissection involving the descending aorta. So this is basically Stanford B or DeBakey's 3. DeBakey's 3 or Stanford B. So in these cases, whenever there is dissection, the first step is control the BP. BP control, you give either beta blockers or the calcium channel blocker, short acting esmolol or nicardipine. And then for DeBakey's 1 or 2, you need to go for surgical repair using the Dacron. DeBakey's 3 can be managed conservatively. Okay, like in this case, you can manage it conservatively, but if it is 1 and 2, then you have to go for surgery. Yes, correct. It is aortic dissection. Which of the following is true about the pathology shown in the image given below? So you can see this is the Fournier's gangrene. Fournier's gangrene. Treatment is to provide subscrotal support. Yet the treatment always in case of Fournier's gangrene do extensive debridement. Testes are preserved, no wait and watch. It is mainly caused by, it can be polymicrobial or monomicrobial. Okay, polymicrobial or monomicrobial. So treatment is, you can go for either, you have to go for debridement of the tissue. You have to go for debridement of the tissue and give IV antibiotics. Okay, so that's why most common it is a polymicrobial type where there is group A hemolytic streptococci, there is anaerobes, gram negatives, gram positives. There can be Vibrio vulnificus also, which is basically a you can say bacteria which is present mainly in the sea. So testes are preserved in this pathology is the correct statement. 41. Testis is preserved in this pathology. Which of the following is true about the increased tone of lower esophageal sphincter? Absence of Meissner's plexus. Meissner's plexus is not for the tone, it is basically for the secretion. Okay, for the tone, basically there is myenteric plexus, and if there is loss of myenteric plexus, then there will be increased tone, basically loss of myenteric plexus. But this increased tone is because of decreased nitric oxide in the lower esophageal sphincter. Nitric oxide will cause relaxation. And if it is decreased, then there will be only the contracting force are occurring, and then it will lead to increased tone. Okay, so decreased NO or the nitric oxide in the lower esophageal sphincter is the reason for the increased tone in the lower esophageal sphincter. I guess this is the last question. Okay, 60-year-old male diagnosed with testicular cancer. Which of the following is true about the spread of the testicular cancer? Okay, so we all know that the lymphatic drainage of the testis goes to the retroperitoneal lymph nodes, that is the pre and the, see, suppose this is the right testis, this is the left testis. If there is a tumor in the left testis, it goes to pre or para-aortic lymph nodes. And if there is a tumor in the right testis, it goes to para-caval or inter-aortocaval lymph nodes. Okay, so inguinal, iliac, obturator, these are not seen, the para-aortic lymph nodes. Okay, so these were the questions of the surgery asked in the exam. I hope all of you did well. And yes, many questions from surgery like these days, as you can see the trend, you will get these many questions, like 40 to 50 questions from the surgery, same amount of questions from the medicine. Okay, so because now the exam is more of the clinical oriented, so they ask these things, you can say the percentage of weightage of these subjects will be more in the upcoming exam also. Okay, Altaf, I don't know about the rest of the paper, but surgery part, I don't think it was very tough. None of the questions were like out of the blue. It was kind of maybe a bit lengthy, and the image-based questions were more. But I guess the questions were standard, and none of the questions were like out of the syllabus or something which cannot be or should not be asked from in FMG entrance. So I hope and I wish you all the best for the results, and after the results we'll talk again. Okay, so thank you very much, and it was a very good discussion, and I wish you all the very best for your exams and also for the future, for the PG also.